Okay, so chapter 21, it's about the respiratory system. So this system includes several organs and structures that help us to inhale oxygen and get rid of CO2, along with controlling the levels of hydrogen ions, so helping us to control pH in our body. So the organs of the respiratory system resides in the head, neck, and thoracic cavity. And this respiratory system is highly linked, this function, with the cardiovascular system, because while the lungs helps to get oxygen and get rid of CO2, the cardiovascular system is what delivers these gases. So we have within this system the nose and the nasal cavity, which forms the start of this respiratory system, and then the pharynx, which is the shared tube between the digestive system and the respiratory system. It's a muscular organ, the pharynx, and part of it helps to bring food into the digestive system, and part of it helps to deliver the air into the trachea and then into the lungs. The larynx is the voice box. It's located anteriorly in our neck, and it is superior to the trachea. The trachea is located in the mediastinum, the space between the left and the right lungs. Now, the trachea will subdivide into the bronchial tree, starting with the primary bronchus, right and left. And they divide at the level of the carina. And then the bronchial tree, it starts forming every time narrower tubes, and it goes deeper into the lungs to help to deliver oxygen and then help to get rid of CO2. Now, this bronchial tree starts as bronchi, which are they are wider passageways of air, and then as the bronchial tree goes distally, it becomes narrow and narrow, forming ultimately what we call the bronchioles. So the bronchioles are small tubules that brings air in and out of our lungs. We have a major subdivision of the respiratory system based on the location of the organs or the structures. Anything above the larynx is upper respiratory tract or upper respiratory system. Anything below there, the larynx, the voice box, is the lower respiratory tract. We need to breathe, of course, to get air and to oxygenate our cells and get rid of the CO2. That's a must for living. Through this breathing, we get in contact with a lot of microorganisms. And these microorganisms can be pathogenic. And these microorganisms that are pathogenic, if they are only residing within the upper respiratory tract and your immune system is strong, you won't have major health problems. The problem is when an upper respiratory infection goes deeper into our respiratory tract, so it goes below the larynx. Someone who has a lower respiratory tract infection is in a serious situation. It can die, the person, of these infections. So what is found in the upper respiratory tract? The nasal cavity, the nasopharynx, the oropharynx, and the larynx. What is found in the lower respiratory tract? The trachea, the bronchi, the bronchioles, and the alveoli. Now, the alveoli is at the end of the respiratory tract, are honeycomb-like little structures that helps in the internal respiration. So actually, in gas exchange between the environment, which is rich in oxygen, hopefully, and our capillaries that are branches of the pulmonary artery. They carry CO2 so that we can exhale the CO2 and we can exchange it for oxygen. Now, in each lung, we have around 150 million alveoli that are surrounded by these capillaries, branches of the pulmonary artery that carries deoxygenated blood. And these alveoli are surrounded by elastic fibers, which is connective tissue. So when we inhale, our bronchioles and our lungs expand, they get filled with air, and then we oxygenate our blood. Exhalation, which is the process of bringing the air out of our lungs and our alveoli, which has which are filled with the lungs filled with alveoli, it's a passive process. These elastic fibers act like if it was a rubber band when it's recoiling. So this elastic tissue compresses these alveoli, and if you don't have any respiratory problems, you exhale the air without any effort. For inhalation, we use muscles, but in exhalation, we don't use muscles. So here is the subdivision of the structures within this respiratory system. So here we have the nose, the nasal cavity, the nasopharynx, the oropharynx, and the larynx that all form part of the upper respiratory tract. And then below the larynx, we have the trachea, the bronchi, the bronchioles, and the alveoli that all form part of the lower respiratory tract. And again, any microorganism that goes into this area, it will cause a lot of trouble. So lower respiratory tract infections are serious. Of course, upper respiratory tract infections as well, because an upper respiratory tract infection can become a lower respiratory tract infection. So that's the anatomical division, upper respiratory tract and lower respiratory tract. Now, we also have a physiological division. So we have something that's called conducting zone or anatomical dead space, in which you only bring air in and out during inhalation and exhalation. Inhalation is bringing air in, exhalation is delivering the air out of our lungs. So in this conducting zone, which runs from the nose up to the bronchioles, the terminal bronchioles, we don't have gas exchange, so that's why it's conducting. So this is the conducting zone. And then in the respiratory zone that is beyond or distal to these terminal bronchioles, that's where we have gas exchange. So oxygen comes into our blood, and then CO2 goes out of our body. So this is the exchange zone or respiratory zone. That's the physiological division. Now, the process of respiration can be broken down into four. So we have pulmonary ventilation, which is the movement of air in and out of our lungs. Pulmon means lung. And then we have pulmonary gas exchange, which is the movement of gases between the lungs and the blood. This is called also as external respiration. And then I previously said internal respiration, but this is external respiration. And then we have the transport of gases. The gases have to be transported. They get transported into the circulatory system by the blood. And then we have gas exchange in our cells, which is called internal respiration. So the cells generate CO2. The capillaries picked up this CO2, but the cells also receive oxygen. The capillaries delivers this oxygen so that the cells can have oxygen available so that you can have production of energy. So this is tissue gas exchange. Other functions of the respiratory system besides exchanging gases, it is to help us to produce voice, speech, detect odors, and expel contents of the body, like during urination, defecation, and childbirth. This is a misspelling there. Another function, it is to assist in the blood flow into the heart. So we have the respiratory pump. Every time that we inhale, we create like a siphon, bringing back the blood into the heart. And then we have the maintenance of specific amounts of hydrogen ions. So we have acid-base balance. And in the lungs, we have an enzyme that is called ACE. Angiotensin converting enzyme. So converts angiotensin 1 into angiotensin 2. We will see this in more detail in the urinary system chapter, but this angiotensin 2 helps to maintain normal blood pressure when someone has a drop in blood pressure. So now let's look at the details of the nasal cavity and the nose. So functions of both is to warm and humidify the inhaled air. We have within this nasal cavity an epithelium, which is simple columnar epithelium with cilia and globed cells that increases the surface area, helping for the air to be humidified. Along with this, we have this mucus that helps to filter out debris. And of course, at the entrance of the nose, which is called the vestibule, we have hair that is called vibrissae. This vibrissae helps together with the mucus that we have in the nasal cavity to trap any debris, including dust, so that you don't have as much dust going into your lungs. And then we have as well antibacterial substances within this area. Now, in the upper part of this nasal cavity, in the roof of the nasal cavity, we have the olfactory epithelium, which is made out of specialized neurons that has receptors to bind odor and molecules. It is found at the roof of our nasal cavity. And then we have on the lateral part of the nasal cavity the nasal conchae, superior, middle, and inferior. This helps to increase the flow of air from the floor of the nasal cavity into the roof of the nasal cavity. The nasal cavity, it has like a triangular shape with the broad floor and the roof of the nasal cavity being narrow. So for the anatomy of the nose, so we have the nasal bones that are located superiorly and medially, forming the nasal bridge. And then laterally and inferiorly, we have the lateral cartilages and also the inferior alar cartilages that give this shape to our nose. Now, the bridge is the area between the eyes, and the area between the eyebrows is the root of the nose. And the anterior part of our nose is called dorsum nasi, which is this. And then the apex will be the tip of the nose, and we have between the apex and the bony septum, we have hyaline cartilage that not only gives the shape to the tip of the nose, but also helps to divide the nasal cavity into the right and left and protects our bony septum, which is posterior to the cartilaginous septum. The nasal septum, it is made by cartilage anteriorly and posteriorly by two bones, the vomer inferiorly and superiorly the perpendicular plate of the ethmoid. Now the opening to the nasal cavity is called the nostrils or anterior nares. So these are the nares or the nostrils. So here is the view of our nose. So this is the root. This is the bridge made by the nasal left and right nasal bones. This is the dorsum nasi. This is the apex, the tip. These are the nares, the openings. And here we have the ala. The ala is made by these alar cartilages, and then we have them in here as well. And here are the lateral cartilages. That all of these gives the shape of the nose. And then medially, a little bit deeper, we have the nasal septum, the cartilaginous nasal septum. So in the posterior nares, we have this opening that is called the choanus, not the nasal conchae. And these posterior nares then will bring the air into the next part of the respiratory system, which will be the nasopharynx. Now, below the nasal conchae, which is superior, middle, inferior, we have spaces that we call the meatuses. Superior meatus, middle meatus, and inferior meatus. Over there, we have openings for filled air spaces that we have in the bones around the nasal cavity, which are called the paranasal sinuses. So the paranasal sinuses open into these superior and middle nasal meatuses, while in the inferior nasal meatuses, we have the opening for the nasal lacrimal canal, which brings the tears from our eyes into the nasal cavity. Now we have these sinuses, frontal, which are the second largest, ethmoidal, which are the smallest. We have the sphenoid, which is the second smallest, and we have the maxillary sinuses, which are the largest. The maxillary sinuses, of course, are found in the maxilla, frontal sinuses in the frontal bone, ethmoidal sinuses, which is also known as ethmoidal cells, we have it in the ethmoid, and then we have these sphenoidal sinuses in the sphenoid. So functions of the sinuses is to warm, humidify, filter the air, and act as a resonance chamber and lighten our skull. So we have, covering the nasal cavity, two types of mucosa. The respiratory mucosa, which is made by this pseudostratified ciliated columnar epithelium with lobed cells that secrete the mucus, and the olfactory mucosa, which is the same type of epithelium, it's just that it's found at the roof. And this is where we have olfactory mucosa, or receptors, neurons, that are part of the olfactory nerve. olfactory nerve is cranial nerve number 1. So this one helps us to smell. Now, within this respiratory mucosa, we have blood vessels like venous sinusoids that sometimes they can get engorged, and then that help us to prevent the mucosa from drying out. And you have engorgement or bringing in more blood every 30 minutes. And sometimes some of these molecules that are found in the air, allergens or antigens, can go and bind there, irritate our mucosa, and cause allergies. Sometimes we have receptors there for certain viruses, like cold virus, for instance, that can bind there and infect our nasal mucosa, and then you have something that is called rhinitis, or inflammation of the nasal mucosa. So here's the view of the internal nasal cavity. So this is the opening or vestibule. This is the roof. This is the floor. This is the posterior opening, which is called choanas. And then this is the lateral view. In the lateral view, you can see the superior, middle, and inferior nasal conchae that are located above the superior, middle, and inferior meanuses. And here we have the view, the longitudinal section of the sphenoid sinuses. This is the sphenoidal sinus in the body of the sphenoid bone. This is the frontal sinus. And then this is the frontal view of these sinuses. So here we have the frontal, here we have the ethmoidal cells, these are the conchae, and this is the maxillary sinus. The maxillary sinus is the largest of the sinuses. Nasopharynx is part of the respiratory system only. It's the upper part of the pharynx. So this is lined with the same respiratory epithelium, which is pseudostratified ciliated columnar. And this is where we have the opening for the pharyngotympanic tube, or eustachian tube. So this is where we connect the middle ear with the pharynx. So if someone has a throat infection, this infection can go into the middle ear through this pharyngotympanic tube, especially in children under the age of 5, because this tube, it is shorter and is horizontal. In adults, it's a little bit longer and it's steep. So that's why children under the age of 5 can get easier middle ear infections in comparison to adults. And then we have within this area the pharyngeal tonsil that helps to trap pathogens. And then the uvula, which is part of the soft palate, it is found anteriorly in this area. So it's like a little hanging indentation within this area. Oropharynx is the next part of the pharynx. It's a shared tube between the oral cavity, part of the digestive system, and the nasal cavity, part of the respiratory system. So in here we have passage of both food and air. Food is supposed to go into the esophagus, while the air is supposed to go into the larynx. And then in the nasal pharynx, we're supposed to have only the passage of air. In the oropharynx, we have this epithelium, non-keratinized, stratified squamous epithelium. Why is this change? Well, because we have food going through this area. And food is hard sometimes, so we have to have a stronger epithelium. So we have several layers of cells that are flat that protects against erosion. In this area, we have this cartilage, which is the epiglottis, that covers the larynx when someone is swallowing either a liquid or a solid food. So that this prevents this from going into the respiratory system. When the glottis is open, well, when we are breathing and when we are speaking, so that the air can go in and out from the larynx. It cannot do both, so it is recommendable, and you heard it before, like, don't speak while you are eating, because you can choke. Now, on the sides of the oropharynx, we have the palatine tonsils, just posterior to the fauces, which is the opening of the oral cavity. And then we have in here another lymphoid tissue, but in the base of the tongue, which will be the lingual tonsil. So all of these lymphoid tissue, the pharyngeal tonsil, palatine tonsil, lingual tonsil protect us against infections. Now, the last part of the pharynx, which is the laryngopharynx, extends from the hyoid bone to the esophagus. And it helps to bring the food into the stomach, and it is lined with the same epithelium as the oropharynx, non-keratinized stratified squamous epithelium. So the pharynx in general, it's a muscular tube. And the laryngopharynx, it's like a funnel that brings the food from the oropharynx into the laryngopharynx. So this is the sagittal view of this pharynx. So here is the three divisions: nasal, above the hard and the soft palate, up to the uvula, the oropharynx just posterior to our tongue, and then the laryngopharynx just posterior to this epiglottis. So this is the view of the epiglottis. And then here's the larynx, and then posterior to the larynx, just anterior to this vertebral column, we have the esophagus. So if you see better all this together, then you can see that air passes from the nares into the nasal cavity, into the choanas, into this nasopharynx, into the oropharynx, and then from there into the larynx, the voice box, which is anterior to the esophagus. And then the air will pass into the trachea and then into the bronchial tree, finishing in the alveoli, the deeper part of the lungs, where we have gas exchange. In here, in these areas that I told you, we don't have gas exchange, we are only conducting. Another name of the conducting zone is anatomical dead zone, because we don't use it for gas exchange. So the larynx specifically extends from the third to the sixth vertebrae, cervical vertebrae. So it's kind of short. And then it helps us to produce sound, because that's where we have the true vocal cords. So these vocal cords are lined with a protective epithelium, non-keratinized stratified epithelium. And then this will be part of these superior vocal cords, which are also known as false. These false vocal cords, they don't vibrate, so they just protect the inferior ones, which are the true vocal cords, which are the ones that vibrate. And this vibration produces sound. And then through tension of these inferior vocal cords that are lined with pseudostratified columnar epithelium, we can change the tone of our voice And then within this epithelium, we have cells that produces mucus that also helps to protect this epithelium, which is a little bit more delicate than the the superior vocal cords. The larynx is made out of cartilage and membranes that connect these cartilages. The most upper one, anterior, will be the thyroid cartilage, that is also known as the Adam's apple. And just below to the thyroid cartilage, we have the cricoid cartilage that looks like a signet ring, with the anterior portion of the ring found posteriorly and the tiny portion that it is in the rings, like ones that goes here in this area, that will be anterior. This is the cricoid cartilage. And the cricoid and the thyroid cartilage are joined by the cricothyroid membrane. This is one of these membranes that can be that you can break in a cricothyroidotomy when someone is choking in order for the person to breathe. Of course, the obstruction has to be above this cricothyroid membrane. And then they insert a tube so the person can breathe. The epiglottis is a broad cartilage that looks like a leaf and that is flexible. It's made of elastic cartilage. So that flexibility allows it to close during swallowing and drinking and open during speaking or breathing. So it's like a flap that goes up and down, closing and opening the larynx. And then in this larynx, between the left and the right side, when you look internally, we have a space. And that space, I mean, if you consider that space between the vocal cords, that space is called the glottis, between the left and the right vocal cords. Why the epiglottis is called epiglottis? Because epi means above. So epi means above. So it's the cartilage above the glottis, which is the space between the left and the right cartilages, the vocal cords. Within the larynx, just close to the epiglottis, we have paired cartilages, like cricoid, epiglottis, and thyroid are only one type of, they are non-paired cartilages. But these ones are paired. So arytenoid are triangular pieces of cartilage that helps to attach the vocal cord and intrinsic muscles of the larynx that involve in sound production. Corniculate, they look like little horns. That's why it's called corniculate, because corn means horns. They are small pieces of cartilage that are found on top of the arytenoid cartilages. And just as the same arytenoid cartilages, they involve in modifying the sound that we produce. And cuneiform, they're found in the lateral wall of the larynx and help to support the epiglottis. So here are the different views of the larynx. So this is the anterior lateral view. You can see in this view, this broad thyroid cartilage function is to protect the vocal cords. And then in here we have the cricoid cartilage that it is connected to the thyroid by this cricothyroid ligament or membrane. Now the thyroid superiorly is connected to the hyoid bone by the thyrohyoid membrane. And then posteriorly, you can see this leaf-like cartilage that is the epiglottis. And then here we have corniculate on top of the arytenoid. And then we have the lateral part, which helps to hold this epiglottis into its space, which will be the cuneiform cartilages. So this is the lateral view of the mid-sagittal view. So here is the epiglottis. Here is the opening of the larynx. Here is the broad plate of the cricoid posteriorly. The smaller part is found anteriorly. This is the thyroid cartilage. And here we have the vocal cords. The upper ones, which are the folds, are also known as vestibular folds. And here we have the lower ones, which are the true. This is the ones that vibrate to make the sound, while these ones protect this the true vocal cords. So the folds protect the true. So one of the signs of laryngitis, when someone has inflammation, whether because if it's an infection or maybe the person uses so much their voice, like singers, professors, is having like a raspy voice. And sometimes it closes so much that the person loses his voice. So, false vocal cords are called vestibular. True vocal cords are called the vocal folds. And the vocal ligaments are elastic bands that pierce wide at the core of the vocal folds. So these are the ones that tenses with the aid of the arytenoid and the corniculate that rotate inward to abduct the vocal folds or rotate outward to abduct them, so that you can produce different tones of voice. So loudness, it is determined by the force of air, while pitch is determined by the tension of the vocal ligaments and the speed of vibration. Higher pitch is when the vocal cords, the ligaments are adducted, so they are close together. And lower pitch is the opposite, when you abduct, when you separate them, because these ligaments will be less tense. And then males, they have typically a lower pitch voice because their vocal ligaments are longer and thicker, and because their larynx is wider. And in females, we have a narrow larynx. And some people born with stenotic larynx, and they never make it to the Grammys. So they cannot shout. Contrary to popular belief, I don't shout, because I have an stenotic larynx. So this is a laryngoscope. So with this device, you depress your tongue and then open the epiglottis so that you can see internally the glottis and the larynx itself. Sometimes this is used for introduce a tube so that the person can breathe, or sometimes even can be used to see if you have an obstruction. So this is the superior view of the larynx with the glottis, the space between the vocal cords. So in this case, we have adducted the vocal cords when you bring inward your cartilages. So that can produce what type of sound? Higher pitch when they are together, or lower pitch when they are apart? Higher. And then when they are separated, because you move these cartilages outward, you release the tension, so these cartilages, these ligaments will be more relaxed. You produce a lower tone of voice, okay? Higher pitch versus low pitch. Now, any questions about the larynx? Now for the trachea, so the trachea is continuous with the larynx, so it's just located below the larynx. It is a tube that is made of mostly cartilaginous rings, C-shaped. They're open posteriorly, and they are interconnected by membranes. The diameter of the trachea typically is 2 centimeters and is between 10 to 12 centimeters in length, a little bit over 4 inches in length. Begins in the inferior neck and extends up to the mediastinum. Ends in the carina, the space or the part where the trachea subdivides into the left and right main or primary bronchus. So the reason for why we have a C-shaped hyaline cartilage rings, we have between 18 to 20 rings, is to allow the expansion of the trachea when we are deeply inhaling, and then contraction when we are exhaling. Now, these cartilages are surrounded by smooth muscle cells, and posteriorly, the endings are connected by the trachealis muscle. The trachealis muscle is very thin, smooth muscle cells that allows as well the expansion of these cartilages when you are breathing deeply. And then this forms like a layer or a wall between the esophagus, which is found posterior to the trachea, and the trachea, which is found anteriorly. So, I don't know if it has happened to you, but it has happened to me, and it's painful. When you swallow a big piece of solid food like an apple or a big gulp of water, sometimes you feel so much pain in this area. Well, it's because you are overexpanding the trachealis muscle toward the trachea, and we have a lot of nerve endings. That's why it feels so painful. Or maybe you have swallowed, which it has happened to me, like a piece of ice. You're crushing ice, and then accidentally, or maybe a candy, that happens as well. It goes to your throat, and then it feels so bad. Well, it's because you're overextending this trachealis muscle. So the carina is the last tracheal cartilage that forms a hook for the mucosa. Anything that goes into your trachea and then touches the carina, like if it's a foreign object, it would trigger a powerful reflex for coughing. It's like a way to say, well, this piece of food or this little bit, it shouldn't go there. Or a peanut, it shouldn't be here. The hope is that someone will cough it up. But sometimes, unfortunately, that doesn't happen. And then it ends up going into the bronchus, either the left or the right. Now, the walls of the trachea. So internally, the inner layer is the mucosa, which is pseudostratified ciliated columnar epithelium with cilia. This cilia helps to sweep away the mucus that is produced by the mucosal glands that we have in the submucosa that secretes this mucus, or the mucus that is secreted by the gloved cells. So we have this sweeping motion then of the cilia, which is called the mucoescalator reflex, to bring away from the trachea, the mucus, and then we swallow that mucus. And then submucosa, we have loose connective tissue, we have a lot of mucosal glands that secrete the mucus, and then we have the cartilage, and then we have the adventitia, which is connective tissue that holds the trachea to the mediastinum, to the surrounding tissue in the mediastinum, so that the trachea won't be moving so much to the sides. Now, ENTs or dental hygienists, dentists, they typically, when you go to have like a cleaning of your teeth, or when you go for a checkup with the ENT, they move the trachea from you to the sides. What they're trying to see is if your trachea is not fixed into the surrounding tissues, because many cancers, many tumors in the neck, they prevent the movement of the trachea to the sides. And if you move it, you can feel a little bit of roughness there. Well, you are moving it against the bodies of the cervical vertebrae. That's why it feels a little bit rough in there. But that's normal. So, here is the anterior view of the trachea, made from, it is located between the larynx to the carina. So it's made out of 18 to 20 C-shaped rings. So if you make a cross-section of one of these rings, and you see it superiorly like this from the top, this is the C-shaped cartilaginous ring. Here you have the epithelium, which is this, pseudostratified ciliated, columnar of course, with mucus, the globed cells. And then here we have the submucosa, which is the next layer that has a lot of these glands that secretes mucus. So your respiratory mucosa, guys, basically helps not only to humidify the air, but also to lubricate the passage so that the air goes smoothly, so that you don't have a dry respiratory system. And then here we have the hyaline cartilage, and then outside of this cartilage we have the adventitia. And now, here is the trachealis muscle that closes these rings of the trachea, and then posteriorly, this is posterior, we have the esophagus. And then if you magnify this region, here we have the carina. And internally, in this carina, we have a lot of receptors for detecting objects. So if you have any object going to here, you have a powerful cough reflex. And then this will be the end point of the trachea, and now your trachea is going to subdivide to make the primary bronchi, the right and the left. Clinical point, smoker's cough. So cigarette irritates this mucosa in the epithelium of the trachea, and in general, the epithelium of the respiratory tract and the oral cavity as well. So this leads to inflammation and secretion of more mucus. Now, something that is known is that nicotine, and I told you this before, paralyzes the movement of the cilia. So the cilia, instead of sweeping away, and that's for vaping too, I believe, just in case. So the mucociliator, let's pretend that like my arms are cilia. The mucociliator reflex is like bringing from proximal regions to distal regions this mucus so that we can swallow it. That's normal. We don't think about it, but we constantly are swallowing our own mucus. But this is the motion, sweeping away. Mucoescalator, going up. With nicotine, These poor cilia, instead of doing this, they stand still, like that. And eventually with time, that inflammation is going to destroy the cilia. But the mucus will be still being produced, and then accumulation of mucus, and then you have plugging of not only your trachea with mucus, but also your bronchioles, which are tiny tubes. The smallest bronchioles are like the diameter of one of your hairs. Imagine your pure bronchioles coated internally with a bunch of mucus that they cannot get rid of. So then, typical coughing of someone who smokes for a long time, it is productive cough, which is basically hearing the mucus, like they cough and it's not dry cough. You can hear the person is kind of semi-choking with their own mucus. And that leads to a lot of respiratory infections as well. Questions? Now for the bronchi, we have left and right that come from the trachea, and then there is anatomical differences that helps you to predict what can happen when someone has aspirated a foreign object. Right is wider, and then it runs more at a steeper angle. Left, it is narrower, longer, and it's more horizontal. So if someone aspirates an object, that object goes into the larynx, into the trachea, and then into the bronchi. Into which lung the person is more likely to have that object going? Into the left or into the right? Into the right. Why? Which bronchus is wider, the right or the left? The right. Which one is less horizontal, the right or the left? The right is less horizontal. It runs more like this and is wider. The other one is more like this, horizontal and narrow. Now, these bronchi, the right and the left, will subdivide into 5 secondary lower bronchi. 3 on the right lung and 2 in the left. And the secondary or lower are going to be subdividing into 10 tertiary bronchi in each lung, branching from the secondary. So the branching continues at about 26 times in total, so that you end up with the bronchioles. So as the bronchioles move from primary or from distal portions, from proximal portions into distal portions, they have anatomical changes. So the amount of smooth muscle increases while the epithelium becomes from respiratory columnar cells into cuboidal cells, and the cartilage decreases. So the bronchioles become more muscular, less cartilaginous, and then the epithelium, from being taller, columnar, becomes shorter, which is cuboidal. And it makes sense. Imagine like narrowing the space and then keep taller cells, so you will have no space for the air to flow through. So that's why the epithelium becomes shorter, so that you can allow the air passage much easier. So here's the bronchial tree. So we have the right main bronchus and the left. So see these how the right one is wider and then more steep than the left. The left is narrower, more horizontal. So these are the primary. And then out of the primaries, we have the lower. 3 on the right, 1, 2, 3, and 2 on the left. And then out of these lowers, we have the tertiary or segmental. And this is a latex-filled bronchial tree. So out of these tertiaries, we form the bronchioles that are going to and become narrower, and they have less cartilage, more muscle, and then you will have the ending into the alveoli. So details about the bronchioles is that they have a diameter that is very narrow, less than 1 millimeter in diameter. They lack cartilage, and they have smooth muscle, and the epithelium is simple cuboidal with few cilia and few, if any, gloved cells. So if you have a bunch of gloved cells in a very narrow space, you have also the chances of clogging them. So that's why you have few, if any, gloved cells. And then these bronchioles, they branch into terminal bronchioles, which are like around 65,000. And this will be the last part of the conducting zone, the terminal bronchioles. The next set of bronchioles will be the respiratory. This is where we actually start having gas exchange. And then these respiratory bronchioles are surrounded by very thin bands of smooth muscle. So you have this to allow the expansion of these bronchioles during breathing. And then you have connected into these bronchioles alveoli, which are little honeycomb chambers that allows the gas exchange. But before this, you have an alveolar duct. And several alveoli, they form a sac. These are grape-like clusters of alveoli. So this is the anatomy of the respiratory zone. So this is the terminal bronchiole. This is the last part where you conduct the air. And then after this, you have gas exchange. So these are the respiratory bronchioles. They are surrounded by thin bands, as you can see, of muscle. And then you have here an alveolar duct. And then all of these clusters of alveoli, this will be the alveolar sac. So this is the closed view of the alveolar sac, and this is the semi-open view. So this is closed, this is open view. So they are like little chambers where you have air coming in and out, and they are surrounded by capillaries that are branches of the pulmonary artery. So just as any capillaries, they have a venous end where you have poor oxygenation and arterial end where you have high oxygenation. And then you have elastic fibers that help for the expansion and collapsing of this. And if you see here in this open view, part of these alveolar ducts, they have some isolated alveoli connected to them. Now, this is an actual view of lung tissue. This is an electron micrograph. So here is an alveoli, another one, and another one, another one, another one. So you have several alveoli here from this cluster. So that's where you have breathing happening, like the exchange of gases. Any questions? So this is the flow of air then. Starting at the nares to the nasal cavity, nasopharynx or pharynx, laryngopharynx, larynx, trachea, primary bronchi, secondary, tertiary, multiple branches of bronchi, up to 26 times, remember? Then bronchioles, terminal bronchioles, respiratory. Up to here is only conducting, up to here is only conducting, and then from terminal to respiratory, you start having your gas exchange. That's why they're called respiratory. Respiration means breathing. And then alveolar ducts and alveolar sacs. Details about the alveoli. The alveoli are made by simple squamous epithelium, the epithelium that allows rapid transfer of gases. That's why we have only one single layer of cells, flat cells. And then the majority of these cells are pneumocytes type 1 or alveolar cells type 1. So they make 90% of this alveolar wall. And then we have pneumocytes type 2 or alveolar cells type 2, which makes 10% of this wall. And these are the ones that secretes a substance that is called surfactant. This surfactant allows the expansion of these alveoli without collapsing. We have a lot of surface tension every time that we breathe inside these chambers. And if it wasn't for this surfactant, you have collapsing. Now, besides these cells, we have macrophages that specifically in this area called dust cells. They help to find anything that is going on in here, anything wrong, and they're part of the immune system. So anything that is swallowed or something that is irritating the lungs, the dust cells hopefully will respond properly. For the respiratory membrane, it is made by 3 layers. One layer of alveolar cells type 1, the basal lamina between the alveolar cells and the capillaries. And this membrane is very thin. It is between 0.2 to 0.6 micrometers, which is about 100th of the thickness of a human hair. So all these membranes makes around 100 square meters or about 1,000 square feet where you can have gas exchange. So this is a known area for gas exchange. And unfortunately, in some diseases, this can be destroyed, like in emphysema. Emphysema can be acquired. Some people can be born without an enzyme, and they can have destruction of this alveolar membrane, or emphysema can be acquired when someone smokes. And then they have less respiratory gas exchange because they have less area to have this gas exchange. This is the last slide that we're going to consider. So here is where we have this respiratory membrane. So if you magnify one of these alveolar membranes, or alveoli, sorry, this is the pneumocytes type 1, simple squamous epithelium. Here we have the pneumocytes type 2, the ones that secrete the surfactant to coat these cells. And then here we have the dust cells, the macrophages. Now, if you magnify this part, you can see this respiratory membrane. This is the basal membrane that connects this simple squamous epithelium from the alveolus and this simple squamous epithelium from these capillaries. So you have gas exchange. So this membrane is very important. Sometimes you can have fibrosis too. So this membrane, instead of being 0.6 micrometers in diameter, become very thick, and then you don't have as much gas exchange. Any questions?